Hi, everyone, and welcome to this breast health education session. We're really happy to be able to bring this session to you during October, which is Breast Cancer Awareness Month. I'm sure you haven't gone far in your travels lately without stumbling upon a pink ribbon or a campaign or fundraising on this topic, as happens every October. And we didn't want to miss the opportunity to be able to provide some education and a discussion and an opportunity to have you ask any questions of health professionals and people who are really knowledgeable about the topic of breast health. So I want to just start out our conversation today by saying thank you very much to the organization To Life, which is a not-for-profit organization that's based in the Capital Region. And To Life educates employees all over the place on good health and risk reduction. So we've got a 45-minute chat today that will go through basic facts about breast cancer and breast health, risk factors, different statistics, and we will go in some amount of depth. And we can go where you would like us to go as well. We also have some time saved at the end for Q&A. So please put any questions that you have in the chat. So before we kick off officially, and again, thank you to Eileen and Mary for joining us. I wanted to share a little bit about my own personal story and why this topic is especially important for me. 4 days into starting my last job several years ago, I was diagnosed myself with breast cancer. And at the time I was, a mid-30s, super healthy, just had my second child. I was actually on a yoga retreat at the time when I discovered a lump in my breast, totally by accident. Just putting on a bathing suit and I was like, oh, what's that? Thought I had maybe like a blocked milk duct. I was still breastfeeding my daughter at the time and had no pain, but there was something clearly there. I thought I had a cyst or something. So that started sort of the chain of events of going to the doctor, getting a biopsy. There's something there. What is that? What could that be? Appointment after appointment until finally I got the call that, I'm so sorry to tell you this, but you have breast cancer. And I actually was at work at the time when I got that phone call from the doctor. And it was one of those flashbulb moments for me when I could tell you exactly where I was sitting, the desk I was sitting at, the room, the way the light was, the time of day. I had grabbed a Post-it note and a pencil and hauled it to a conference room so that I could take notes, because that was the only thing I could think to do at the time. And, fast forward, I found out that I have the breast cancer, the BRCA1 mutation, which significantly increases the likelihood of you getting breast cancer during your lifetime. But I was the first person in my family to discover that gene. So it wasn't even on my radar. I didn't have a lot of breast cancer in my family. And so it wasn't something that was top of mind for me. And then after receiving that diagnosis, I had a bilateral mastectomy. I began chemo in July of that year. I had a hysterectomy because you have increased chance with the Bracca mutation of having other kinds of cancers in addition to breast cancer. And then I had radiation because the cancer had already spread to one of my lymph nodes. And it's been quite a journey. I'm happy to say now I'm 4 years without evidence of disease. But that period of time of going through that 9-month course of treatment with 2 young kids, I had a 3- and 4-year-old at the time. And I worked through it, which seems insane to me now, but that was my coping mechanism and way to sort of distract from how sick I was feeling and how just scary it was to go through that experience and have triple negative breast cancer, which is super aggressive and responds to chemo well, but not to other forms of hormone treatment and other pretty commonly used treatment methods. And I thought that, one, I think the support that I received during that time was incredibly important. The education and resources that are out there that are available to be consumed and to be understood are so important. Everybody's going through something. Everybody knows somebody who's had breast cancer. There's, I'm sure, people on the phone who've had it or had someone in their family go through an experience like that. It's an incredibly important thing for us to talk about and to be aware of. I'm super aware during this month of all the term pink washing of this idea that breast cancer is the good kind of cancer. And I've had people say to me, oh, well, it's just breast cancer, or, oh, thank God, it's just the breast cancer. And it's like, well, the breast cancer kills 4,000 women a year. And men as well can get breast cancer. So I wanted to just be real about the experience, put it out there for the discussion. My experience having gone through all of that inspired me to coach women who are going through it, also who are either in treatment or just out of treatment, in survival mode, trying to figure out what the new normal looks like and what that means for them and the rest of their lives. And so I'm super open about my experience and have been really since the time I started going through it. And I just offer out, after this session, if there's anyone who wants to have a chat or reach out or be connected to other resources, I'm more than happy to have that conversation with anyone in the organization. So I just want to share that. It's an important topic. It's a timely topic. And we really can't spend too much time talking about it. So with that, I'm going to turn it over to Eileen with To Life to give us a little bit more of an intro and to get us into the heart of our discussion today with Mary. So Eileen, over to you, and thank you again so much for being here today.
So I want to say hello and to welcome. We now have a great crowd on that's participating in this and hearing my voice and hearing the other voices. And I want to say thank you to Jerry and Gabby for setting us up today and for prioritizing health. And that's really what you're doing by paying attention and giving us some attention and time for this, both talk and then some back and forth dialogue. You are prioritizing your health. And it's that proactive element that will, help keep us as healthy as we can be. And so, Jerry Lynn made a decision at some point, which was, I'm going to have that, that lump or that, something is not right looked at, and not ignoring it and dismissing it and saying, I'm too busy, I'll deal with it another time, which is exactly where the October awareness campaign gets its roots of not pushing it off to the side. So with that, we're going to get right into it. Actually, I'll introduce myself as Eileen Bird. I'm the director of To Life. We're a breast cancer support organization that helps individuals that have been diagnosed. And a breast cancer survivor would be anyone who has been diagnosed and received the notice that they've had breast cancer on through their entire course of treatment and beyond. And so, but I'm really happy to have with us Mary Bowen. Mary Bowen is a nurse navigator with St. Peter's Hospital here in the Albany area. Mary has spent her career as a oncology nurse, a trained oncology nurse, and worked with breast cancer patients for much of her career. And so we're really delighted to have Mary run this workshop today. But Mary is also a member of the To Life board. So prioritizing health is really in her DNA. With that, I'm going to turn it over to Mary and say thank you.
Welcome to upstate New York, wherever you are. I know for some of you, it's probably still fairly early in the morning. So what a way to get your day started out, really. Geraldine, I can't thank you enough for sharing your personal history, personal story. Often I'm the person that is calling someone like you to give them that news. So I have to be very in tune to what the patient is going through and have to try to develop a relationship almost immediately whether we've met face to face or not. And just so you know, anyone like me who is in that position really does care. So lean into your caregivers, anyone who ever needs it, because we are here to help you through it. I was thinking earlier today about the fact that the pink ribbon signifies breast cancer. Each month, I think, has a cancer that it represents, and everyone is a different color. And of course, probably most people would assume that the color pink for the breast cancer ribbon was devised because it's mostly a female illness. And of course, girls are pink and boys are blue. So why wouldn't it be pink? So I decided to do a little research in color psychology, and actually pink is a sign of hope. It's a positive color that inspires warmth and comforting feelings. It signifies unconditional love and understanding. And it also signifies giving and receiving care. So that's really what it's all about. And, you know, a lot of people think that there's too much emphasis on the pink and the pink ribbons and the celebrations and the fun. But hey, it's a sign of unconditional care, loving, understanding, and support. So you can tell people it's not just because it's a female illness. There are men who also have breast cancer, and they deserve the same unconditional love and caring as the women who get it. So that's what pink is all about. Anyway, before we get into the real nuts and bolts, I just wanted to tell you a little bit about To Life. We're a nonprofit organization located in the suburb of Albany, New York. Albany is the capital of New York State, and Del Mar is a suburb. We also have an office in another suburb of Saratoga where Fingerpaint's office is located. To Life came about in 1998 when our founder was in her 30s and diagnosed with breast cancer, also the Bracca gene. I think she's been through 2 bouts of breast cancer now, but is happily retired from a law practice, very healthy and doing well. Started out as a grassroots, very small support organization, and now we serve the Capital District region, which is 10 counties. We provide education, support groups, programs, and services, not only to breast cancer patients, but to their families and caregivers. We have boutique services where women can come to be fitted for bras, prosthetics, wigs, hats, scarves, and oftentimes when they're in one of our offices being fitted for a necessary item, they do get involved in support groups, wellness programs. We have some really, really world-class speakers for our educational programs, and very well received, not only by patients and their families, but also local medical care providers. So To Life is a real gift to our area. The program goals for today would be to talk about breast health, cancer prevention, risk factors for breast cancer, and the importance of self-awareness, screening, and early detection. And of course, we'd like to leave some time for discussion. So 1 in 8 women is diagnosed with breast cancer over the course of their lifetime. As you can see, a lot less men are diagnosed. It's 1 in 833, but still in my, say 20 years of dealing with breast cancer, I've seen, a fair number of men be diagnosed and luckily survive breast cancer. In 2021, breast cancer became the most diagnosed cancer for women in the United States overall. Most common cancer globally. It's the second leading cause of death among US women. Of course, the first leading cause is heart disease. Most breast cancer is diagnosed in women aged 50 plus. And as a healthcare provider, I have to say we are much more concerned or alarmed that a woman who's diagnosed under the age of 50 probably has a more aggressive type. Mortality rates decreased between 1989 and 2015 significantly. 39% is, in my mind, quite significant, and it's thought to be because of earlier detection, more education, and more treatment advances. Unfortunately, breast cancer is more common in Black women than in white women, and Black women are 40% more likely to die of breast cancer. We'll touch on some of the theories for the reason for that later in the discussion, but unfortunately, it is a fact. And then with regard to the Bracca mutation, which Geraldine discussed, Bracca just stands for breast cancer, BRCA, breast cancer, mutation or gene, which is passed down through families. And although not everyone in a family may carry the Bracca gene, certainly it puts everyone at greater risk of developing breast cancer and some other cancers throughout their lifetime. Northern European Jewish women, which that group of Jews is called Ashkenazi Jews, are the most likely population to develop Bracca mutation related breast cancer. Black and Latinas tend to have a more aggressive type of breast cancer when they develop it, called triple negative breast cancer. That means that we really can't identify what fertilized their cancer. In a pathology lab, when cancer is diagnosed, the pathologists go on and examine the tissue even further to figure out if it was fertilized by hormones or by certain proteins. But in triple negative breast cancer, everything they test for comes out negative. So I hate to say it, but the treatment of those types of breast cancers, like a triple negative breast cancer, is much more difficult and maybe less effective because we have nothing to target. We have to use sort of a general treatment instead of something that is specifically targeted to a specific type of breast cancer. So oftentimes it's diagnosed at later stages and the treatment is less effective. We don't have a lot of data yet on breast cancer in the transgender community. Certainly collecting data, certainly trying to get the word out there that those who are in the process of a sex change or who are transgendered need to be just as aware as anyone else about their risk factors and the need for screening. So education is power, knowledge is power, and everyone needs to have a physician partner who they trust and who they will go to when they are concerned or when they just need some screening. So many risks for breast cancer. I probably don't have to read them all to you, but I will focus on the ones that are the highest risks. Naturally, as we age, we're all more prone to develop some sort of illness, whether it's cancer, heart disease, neurologic illnesses. As we age, we are more likely to develop something. So aging is a big one. Obviously, as we already learned, females are more prone to breast cancer. So if you're born a female, then you're going to be more likely to develop breast cancer. Family history, especially a first-degree relative, such as a mother or sister with breast cancer, puts you at higher risk. breast density, which is mostly seen in younger women. Young women have thicker tissue in their breasts and less fat in their breasts, so it's harder to see through. So could a tumor be missed on a screening exam? Yes, which is also why women with breast density should also have ultrasounds. I know in the state of New York, a law was passed that every woman who has dense breasts should be allowed to have ultrasound along with their screening mammogram. Women who have had, say, a precancer or a high-risk lesion removed from their breast are watched more closely, are screened more often, and are more likely to develop a breast cancer. So those are people who have to be watched very, very closely. And as I said, I don't think I need to read them all to you, but good things to be aware of. And then, of course, there are things that we can do to prevent ourselves from developing breast cancer. And that would be on the next slide, Eileen. Lifestyle changes. One thing that we know for sure, and certainly not to blame anyone who has breast cancer and happens to be overweight or obese, is to maintain as close to normal a weight and low body fat as possible. We do know that there is a correlation between obesity and breast cancer or recurrence of breast cancer. So one conversation we do have with overweight women, and it's a tough conversation because we don't want people to feel badly about themselves, is that they need to have a healthier diet, lower fat, lower carbohydrates, and really get close to a normal weight. And that would include some exercise. We also do know that, say, 180 minutes of exercise a week can reduce the risk of developing breast cancer, along with many other illnesses, including heart disease. We don't know for sure that smoking has a correlation with breast cancer, but obviously we all know that we shouldn't smoke. We do know that alcohol does have a correlation with breast cancer, so we recommend no more than 1 alcoholic drink per day. And of course, you could say, well, how about if I have a 12-ounce glass of wine? I don't know why anyone would want to, but 12-ounce glass of wine is a really large glass. We're talking about 4 ounces of wine or liquor, 8 ounces of beer. Those are the normal servings of alcohol, and no more than 1 a day or 7 per week. And then again, there's a few other factors there that may or may not be really strongly indicated in the development of breast cancer. Again, you know, sometimes women have been on birth control pills for many years, or say a 70-year-old woman has been on hormone replacement therapy to alleviate menopausal symptoms for many years. We don't want women to feel like they or their physician caused their cancer. Some things we just can't prove are related to the development of the breast cancer, but we think there could be a correlation. Okay, so on to the anatomy of the breast. There will not be a test on this, so you don't have to remember everything, but maybe some basic vocabulary is good. Most people know what the nipple is, and then the darker skinned area around the nipple is called the areola, and certainly women can develop breast cancer in that area. It's not always just found in the, say, meatier, thicker area of the breast. We can definitely find cancers around the nipple or areola. And unfortunately, sometimes if a cancer is found either in that area or very close to that area, in the process of surgery, the nipple and areola do have to be removed. So it can also be rather disfiguring. The pectoralis muscle is the major muscle behind the breast. The breast is made up of a lot of duct work, just like a building or a home. In the case of the breast, the ductwork is there to deliver milk out through the nipple when a woman is breastfeeding. You see the word lobules there. That's the glands where the milk is produced in the breast. It's connected to the ducts, so it goes from the lobule out through the ducts. And of course, our ribs and our ligaments and chest wall are all sitting there behind the breast, and the pectoralis muscle too. Unfortunately, cancer can spread throughout all of those areas. And of course, the lymph nodes. I neglected to mention lymph nodes, which we have thousands of throughout our body. The lymph nodes that we worry about the most are the ones adjacent to the breast and then up under the underarm. The underarm is also called the axilla. That's axilla. So you'll hear the term axillary lymph nodes. Those are the lymph nodes under the arm. And we most always test at least a few of those during breast cancer surgery, just to be absolutely sure that there has been no spread to that area.
Mary, there's a question I just wanted to flag based on the risk factors that you were discussing a moment ago around hormone replacement, women who are taking hormones over a long period of time. There's a question whether it's specifically the risk factors around estrogen replacement, or if that it also, the risk factor applies to other hormone replacement like thyroid replacement.
No, that is mostly related to estrogen replacement. The majority of breast cancers are estrogen driven. So that's the one that we really want to know about. And oftentimes if a woman is diagnosed with an estrogen sensitive breast cancer, we do leave it up to their gynecologist who's prescribing the hormone replacement, but most often we ask them to discontinue taking their estrogen replacement, because we certainly don't want to add any fuel to the fire. But no, not the thyroid hormones or other hormones. Really, not even progesterone so much as estrogen. That's the one that tends to be the real fertilizer.
Yeah, thank you. And one other question popped in, which is, how do you know if you have dense breasts?
The only way to know is to have a screening mammogram, and the radiologist who's reading your mammogram will mention that in their report. They actually classify how dense your breasts are. So if they are classified as dense breasts, then you should also be having ultrasound as part of your annual screening.
Thank you.
And Mary and Jared, that actually answers another question that came on from someone who had received their mammogram results, which did not show any cancer issue. And so she was told, though, at the time that she had dense breasts. And so therefore, the subsequent protocol, and I think this is more widely accepted everywhere around the country now, is to have that ultrasound. Which,
absolutely.
Okay. And so
absolutely. And, you know, I hate to say it, but we have to be our own best advocates. So don't sit home waiting for Dr. Smith to call you and say, hey, I noticed you have dense breasts. Maybe you should get an ultrasound. We have to advocate for ourselves, unfortunately. But that is your right, and you deserve to have that ultrasound. Every modality of imaging has its strengths and weaknesses. So the more combinations that we can afford ourselves, the more likely that we may find something before it becomes a big deal.
And Mary, going back to risk factors, there's a question here in the chat about what about the use of a hormonal IUD or oral contraception over a period of time? Does that increase the risk of developing breast cancer?
You know, we're not super sure on that, but to be better safe than sorry, if a woman is diagnosed with breast cancer that is hormonally driven, we do ask them to discontinue the use of anything that could add extra estrogen mostly. Again, that could fuel the flame. So I'll just move on to some of the most common non-cancerous breast conditions, and especially the one that is called fibroadenoma is very common in younger women. We get a lot of, 20 some odd year olds and maybe even late teens here in the breast center being sent in by their family physician because they found a lump in their breast. And, 9 times out of 10, probably, it's going to be what we call a fibroadenoma. Younger women have very lumpy, bumpy, fibrous breasts. Fibroadenomas sometimes become quite painful, either around the menstrual cycle or if a woman tends to take in a lot of caffeine, it can really make the breast sensitive. But most of the time, that's what it turns out to be, thank goodness. But worth taking a look at, because if we can find one breast cancer at an early stage in a young woman, when many others have only been fibroadenoma, we're happy to look at all of them. And then, of course, some people in general tend to develop cysts anywhere in their body, more often than others. And there are women who tend to develop breast cysts. Again, they can appear as a lump. It can cause discomfort. We'd rather have you come in and have some imaging and possibly even a biopsy or at least an aspiration of some fluid out of that area than to miss a breast cancer. So don't ever feel like you're taking up someone's time when it's probably going to be a benign condition. We'd rather know for sure. So that brings us to another conversation. How do you know what to look for? Well, first off, you have to know your own body. There are some organizations now who are not really encouraging women to do the monthly self-breast exam that we've always heard about. But you do need to know your own body. And the only way to know that is to examine yourself and to be aware of any changes, which again, may be pain if you're not examining yourself. But certainly you look at yourself every day in the mirror, so you might notice a change in the shape of your breasts, the size of your breasts, the color of the skin. You may have some redness, some itchiness or scaliness. The nipple, for most women, the nipple sticks out. But sometimes if you're having an issue, it will retract, which means it'll become more flat or even go inward. That is definitely a change that you should mention to your physician. Dimpling of the skin, almost to the point where it looks like cellulite that you get in other parts of your body. Most of us do anyway. Any changes at all should be brought to the attention of a healthcare provider. So know your body. That's a big one. Next slide is regarding breast health care. Now, breast imaging obviously is not a routine part of breast health care for most women until they become about 40 years old. Sometimes if there's a fairly strong family history of breast cancer, women will start earlier, meaning age 35 or 38 or 10 years younger than their mother was diagnosed. For instance, if a woman has a mother who was diagnosed at age 40, then that woman should start screening at age 30. So 10 years younger than your mother was diagnosed. Geraldine, that's probably going to be difficult for your daughter or daughters. Again, that's something to talk to their healthcare providers about. I don't know if they're going to want a 20-year-old to have annual mammograms and ultrasounds, but definitely they will be watched very closely, and that's a good thing. Again, the breast self-exam, knowing your own body, being self-aware, and then a clinical breast exam. That's different than a self-breast exam. Clinical breast exam is when you go to the doctor for a physical, and hopefully they actually do lay hands on you. It's not quite as thorough as it used to be, but once a year, whether it's your primary care physician or your gynecologist, they should do a thorough breast exam, including up into the underarm or axilla where we could find some abnormal lymph nodes. So the
Mary, you mentioned that there are some physicians that are not recommending monthly health checks or advocating the self-exam monthly. Why
yeah,
is that?
breast exam. Not really sure, to be honest. And I don't think it's so much physicians as some organizations out there. They're feeling that maybe women aren't being thorough enough to do an adequate breast exam, but overall, those of us in the healthcare field feel like, okay, it may not be as thorough as our clinical breast exam, but if you know your body and you're aware of changes, then it's worth doing on a regular basis. And I will say, if you're going to do monthly self-breast exams, you should time it so it's at least a week after your menstrual period has begun. Most of us know that our breasts do undergo some changes just before our menstrual periods. And so we say at least 7 days after the start of a menstrual period, just to have our breasts get back to their normal texture and sensation.
Mary, it's Eileen. I wanted to add on to this, and Jerry, you have a question about other organizations. And there was a concern a number of years ago that some people were doing their own monthly exam to the point where they were not going to their physician on a yearly basis and receiving, as Mary describes, the clinical breast exam. And so that effort of doing your own examination needs to be accompanied by your clinical breast exam and subsequent imaging. And it kind of that's why we really like this particular slide, because it talks about the holistic a proactive stance that we need to take. And so imaging becomes a part of it. So I'll leave it at that, but you covered it nicely, Mary. Thank you.
Yeah, and that really is a good slide. It puts you in a position of strength if you're combining your own self-breast exam, your clinical breast exam, and breast imaging when it's determined to be the appropriate time to begin. And I think that our next slide speaks to that again, talking about breast cancer screening. Definitely an annual mammogram, screening mammogram, beginning at the age of 40. If there's a problem before the age of 40, then we call that a diagnostic workup, meaning we'll do more angles and more pictures because we're looking for a problem, since a woman is reporting some changes. Ultrasounds, especially if you have very dense breasts, and probably if you're considered to be at high risk of breast cancer. And also MRIs in women who are determined to be at very high risk of breast cancer will sometimes alternate an imaging study every 6 months. So an MRI, then 6 months from now, a mammogram, and probably an ultrasound, and just alternating that every 6 months. And of course, as Eileen said, the self-breast exam is never a substitute for medical care.
Mary, is there, there's a couple of questions around screening here in the chat. Can younger women get sonograms instead of mammograms?
No, it's not considered to be adequate. So one doesn't take the place of the other. As I said before, they each have their own strengths and weaknesses. So we would want to do a thorough exam of the breast radiologically, and that would mean both mammogram and ultrasound. And really, mammogram is the gold standard for breast imaging.
Mary, there is one more question, which I'll throw in here now.
Sure.
OBGYN has ordered an ultrasound for someone under 40 due to pain in the breast area without any lumps or other symptoms. versus ordering a mammogram and the ultrasound versus ordering the mammogram and the ultrasound comes back clear, is it common not to order a follow-up mammogram?
I know around here, and I don't think it's just a statewide thing, our radiologists would want a baseline or initial screening mammogram to go along with that ultrasound. We may not ultrasound both breasts. We may only ultrasound the one, where the patient is having the complaint, but yeah, they feel it's most thorough to do a baseline screening mammogram at that point.
So then the comment I would make now back to the questioner would be to circle back around with your physician.
That's right.
For the mammogram, goes kind of back to the advocating for
yourself.
For herself. Okay, thanks, Mary.
Sure. Next screen is regarding the transgender community, which I think I touched on a little bit before. It's a new world we're in, fairly new anyway, and so we don't have a lot of good hard data, but as is mentioned here, the Clinical Journal of Oncology Nursing and Fenway Health is a reputable transgender health clinic. They have a lot of information out on the internet about transgender care. So for women, especially those who have used feminizing hormones for 5 years or more, we do believe that an annual mammogram should begin at age 50. Chest wall exam for transgender men who have had surgery. So that would be female to male. Still should have at least a good physical exam annually. And again, know their own body and know when they notice, either through visual check or palpation, which means feeling with the hand, that there is something different. And then transgender men who have not had chest reconstructive surgery should follow the same guidelines as cisgender women. And just in case you don't know that, cisgender means the gender that you were born at. So if this person was born a female, they should continue to abide by the guidelines that are outlined for females. And then the different types of breast imaging. Now, standard mammogram used to be what we call 2D, where they just looked at two different angles of the breast. Really, 3D over the past year or two has become the gold standard. In fact, where I work, we're not even doing 2D anymore. So 3D is really, really the gold standard, and any reputable breast center should be using 3D mammogram at this point in time. As you can see under the heading of breast density, the one that is extremely dense is pretty difficult to see through because of the cloudiness and the thick white tissue that is on the inside. So that's why it's nice to be able to have an ultrasound too, just to get a different view of the breast.
Mary, there's a question on density that's popped up here. Did dense breasts make it more likely to develop breast cancer or just less likely to discover it?
Right, just less likely to discover it because there may be something hiding in there that we can't see with a standard mammogram or even an ultrasound. But, in order to give it the best shot, that's why we like to do both mammogram and ultrasound, because it can be more difficult to see through the breasts, but not more likely to put you at risk of breast cancer. Next slide, we can see both the ultrasound and MRIs. Probably most people have had an ultrasound of some sort in their life. I guess mammogram gets the reputation for being uncomfortable or downright painful because the breast has to be compressed between two paddles in order to do the mammogram. In my opinion, and I've certainly had plenty of mammograms by this point in my life, I think it's worth a few minutes of discomfort for what it can do for you. So, well, we all have different pain tolerances too. So I will acknowledge that it is uncomfortable for some people, but well worth the benefit. Ultrasound is not uncomfortable for most people. It just involves having some nice warm gel placed on the area of the body that's being ultrasounded, and then the ultrasound technologist uses a probe to go over the whole area and take pictures that will be recorded and read by a radiologist. Breast MRI. Mm-hmm. Go ahead.
Mary, there's someone who's raised their hand, and I have unmuted that person, and I think you would ask another question. Would you like to jump in right now?
Q&A. So let's see.
Keep going. And
I see a lot of questions. I just had a mammogram in May. Do I need to have a mammogram every year if I'm 59? Absolutely. Yes. Yes, we would recommend annual mammogram screening for someone who's 59. You know, when you get up to 80, hopefully, maybe you can rethink whether you want to continue to come in for annual mammograms, but we have plenty of 80-plus-year-old women who are high functioning, and they do still come in for their annual screening mammograms. Not sure if that was the question you were referring to, though.
Why don't we keep going?
All right, and then we'll just touch on them all.
Okay.
So the breast MRI, as you can see in the picture, the positioning is a little uncomfortable for some people. You have to lie face down with your arms out in front of you. There is an intravenous put in because you do need contrast for a breast MRI. But that is not a routine exam. That's really for someone who is considered to be quite high risk, or for someone who has already been diagnosed with breast cancer and the doctor wants to get a better look at both breasts. So back to the clinical breast exam, which I hope everyone is receiving, either from their primary care physician or their gynecologist. It should be very thorough, and by that I mean covering the whole area from, say, the collarbone right down below the breast tissue, and then over every little centimeter of the breast tissue, and then out to the underarm or axilla, so that we could feel any enlarged or abnormal lymph nodes that might be there. And the same for the breast self-exam. You should be very thorough about covering every area, using the fat pads of the first 3 fingers, and different levels of pressure. Start out with light pressure, and then going down to medium, and then more hard pressure. Not for everyone, but for some women, you can actually feel right down to the ribs. And so that would be really, really thorough if you covered every little centimeter, as I said, right from the collarbone down, because the collarbone area does have lymph nodes, and sometimes people do find enlarged lymph nodes in that area, both out to the side of the breast, both to the side and toward the center, a little bit below the breast, and then out to the underarm with both light and deep pressure. And the more you do it, the easier it gets and the less time it takes you. And then we just have a depiction of the 3 levels of pressure that I talked about it already. Light, mid, and then deep pressure. Sort of in a circular motion. But again, whatever you do, do it consistently so that you will notice changes. And it sounds kind of obvious, but I'm going to say it. If you feel or see a change, contact your provider. Doesn't matter. I put primary care provider on there because most people do have a primary care physician. But if you happen to have a gynecologist who you're very connected with and see on a regular basis, they are certainly equipped to guide you through a problem with your breast. Most of us these days do use the internet to get our information. So we have put on some organizations here that will give resources for everyone. The American Cancer Society, of course, that's cancer.org, has information about cancer itself, all different kinds of cancer, and a lot of supportive information for caregivers or for friends and family of someone with cancer. So don't ever hesitate to use them. Then the National Cancer Institute, of course, is going to be more scientific information, but it's a good, reliable source because, as we all know, there is some not so reliable information out there on the internet. I always encourage women not to get involved in blogs unless, again, it's from a really reliable source, because sometimes you just get people who are very angry and misinformed, and they like to share their bad news with the rest of the world and just spreads a lot of inaccurate information. Susan Komen Foundation is a wonderful organization, and they do provide reliable information. Another good one is the Mayo Clinic. And then, of course, the organization that is sponsoring this talk today, and we are To Life with an exclamation point. There are other networks out there for women who are diagnosed under the age of 50. That's called the Young Survivors Coalition. It's a national group, but a lot of areas have local groups who are very supportive of each other and do a lot of research and share information. So it's very reliable and very supportive to women who are going through breast cancer. And then, of course, the Sisters Network for African American women. So I think, number one, we're getting close to ending this whole session, but we do have time for more questions for sure.
There's a couple more here.
Yeah, I did also want to mention, not just related to breast cancer, but that everyone should have their needs and wishes known, either in writing, not necessarily legally, but through their physician's office or through a hospital, by choosing a healthcare proxy. And that means obviously discussing it with someone who's very close to you and someone that you trust, about being the person or people to make decisions for you if a time comes when you cannot make decisions for yourself. Write down your wishes, write down what you would and would not want in different situations when you could not make those decisions, and make your wishes known to healthcare providers. You really should have someone assigned to do that for you. And it can be more than one person, so that it doesn't all fall onto one person. But just wanted to bring that up, that we all need advanced care directives. And that's what that means, making your wishes known and assigning someone to make decisions for you in case you can't at some point. Sorry to interrupt you.
No, this is great. Thank you for sharing that. That's an important tip. There's one other resource that I want to mention. If anyone knows someone under the age of 40 who's got any kind of cancer, there's another support organization that I've worked with personally called Immerman's Angels that does essentially a cancer mentor matching service. Because the younger you are, it can be difficult to find people who've walked in your shoes and have a similar diagnosis. So this is a Chicago-based not-for-profit that matches essentially people going through cancer with someone who's had it. And you can have sort of someone who's at that same age and had a similar diagnosis to you to have that point of connection. I know we have just a couple of minutes left, and there are a couple more questions I just want to make sure that we tee up to you, Mary. One is, Does having a breast reduction make you more or less likely to develop breast cancer?
It does not affect your risk of developing breast cancer. I would say that, because scar tissue can develop, again, it might be more difficult to visualize a reconstructed or reduced breast. So probably a good idea to have both mammogram and ultrasound.
And is there a recommendation around women with Bracca mutation to refrain from hormonal birth control?
No, there is not. Nope. Again, it would only be if a hormonally driven breast cancer were discovered that we may ask the woman to discontinue any hormone use.
Yeah. And I think you may have touched on this one, but there's a question about when during the month should be doing the exam. And what about for women who have irregular or no periods?
For no periods, I would say just do it at about the same time every month. So if you choose to do it on the first of every month, great. For someone who has periods regularly or even irregular periods, at least wait 7 days after the start of your period before you do your self-breast exam.
Thank you. I think that we've answered all the questions that popped up in the chat. And I see that we're right at 1 o'clock Eastern time. If there's any more questions here, please pop them in. But thank you so much, Mary and Eileen, for bringing us all this information today. We had a lot of
having us.
Great discussion, and this is really awesome questions that were asked as well.
They are.
So thank you for asking these questions. And
I'm looking through the questions now. I see more of a comment than a question. Someone was told by a doctor once that often spouses will notice the difference before the woman does, and that's true. Yeah, I've heard that quite a few times, and believe it or not, I've even heard, and this can't be proven, but I've had women tell me that their cat, who they often sleep with or, play with a lot, their cats will focus on that exact area where a tumor is. I kind of believe that. I know that animals are very intuitive, and why not? If you spend that much time together, then whether it's a human being or a pet, they're going to know that something is different. So don't discount it.
it's amazing.
Actually, I really appreciated all the questions. And Mary, I know that sometimes it's difficult to balance the questions as you're keeping your talk track on track, and you were able to do that, and I commend you for that. So that,
thank you. Actually, it makes me less nervous for some reason if I can just speak from my head and not have to be following a script. So,
but I think it also shows that people. Oh, I'm sorry.
No, I appreciate it too. Yeah. Why are okay? We already answered that one.
Okay, is there anything new there?
I don't think there's anything new. I went through them all. I think we've covered them. Someone said, yeah, my dog knew I was pregnant before I did. I had that experience too, actually. My dog got a little bit feisty, and then I found out I was pregnant.
I believe it. They know they're humans.
Oh.
Yes.
Okay, so Jerry, thank you for having us. And Gabby, thank you for organizing us today. Mary, that was really thorough, really good information. And I think it comes from a place that only wants people to be at their optimal health. And sometimes that seems like there's a lot of common sense baked into some of the slides when I kind of listen to the way that you speak. And then sometimes you're adding balance, so people's like, oh, well, why is this particular recommendation important? And you've kind of added some of that balance. You also, talk about some of the statistics so that people can put their risk factors into perspective and not thinking that just because they might know someone that has been diagnosed, that automatically means that they're going to be diagnosed. The real truth is that A lot of people go for mammograms, and almost all of them are they have no breast cancer discovered. And so
Right.
it's a
Oh,
real
definitely.
thing. Because I think a lot of people are concerned. It's like, if I go for a mammogram, they're going to find something. And the fact of the matter is, they most likely will not.
Yeah, as I had posted, I actually knew that I had cancer, but they wanted a baseline mammo because I had not had one, because I was in my mid-30s at the time.
Yeah.
Because my breasts were so dense, it came back. They were like, it's normal. But I
Uh-huh.
had already found so
Already
they just
knew.
wanted to have that done, but then, it was the sonogram, the ultrasound that actually found it. So it's so important to understand that about mammograms. I didn't realize that until I went on this journey.
Yeah. Well, you're making good out of it, right? Making lemonade out of lemons, helping others through the process.
Absolutely. Thank you. Thank you so much, Mary and Eileen. This is a really, really great discussion. I appreciate you taking time out of your day and sharing this knowledge with us.
We enjoyed it. Thank you very much.
Have a great rest of your week. Thank you, everybody, for joining.